Good afternoon. Thank you for allowing me to present this study. It's a prospective evaluation of factors affecting serum testosterone level after Testopel therapy in patients with late onset hypogonadism. As all of us know, late onset hypogonadism in aging males is a debated issue, particularly its relevance outside of sexual and reproductive functions and its associations with the overall morbidity of the patient. Long-acting testosterone pellets have gained popularity as a treatment option, but the implantation dosage and frequency still remains uncertain. We set out to do a prospective study to identify factors affecting testosterone levels post-Testopel implantation in these patients with late onset hypogonadism. And we tried to extrapolate this to assess the dosage and frequency at which these pellets need to be implanted. The variables studied were body mass index. We did genotyping for cytochrome 3A4, the pathway for testosterone metabolism, and we also wanted to study any variations in T levels with concomitant medications, especially which are metabolized through the same pathway. From January 2013 to January 2014, total of 200 implantation of Testopel was done in 109 consecutive patients, and they were evaluated prospectively. All patients had implantations of 12 pellets inserted subcutaneously in the gluteal region in 2 tracts. The data analyzed, like I said, was patient demographics, the body mass index, 2-week and 3-month post-implantation serum testosterone levels, concomitant medications that are inducers or inhibitors of cytochrome 3A4, any post-implantation untoward effects, and a univariate and multivariate logistic regression analysis was performed to evaluate factors associated with serum testosterone at 3 months. Total patients were 200, average age was 56.3, mean body mass index was 31.5 kilograms per meter squared. The patients who had BMIs below 30 were 42.5%, and above 30, 57.5%. Abnormal genotype for cytochrome 3A4 was found in 23% of patients. Medications affecting cytochrome 3A4 were 21 patients, out of which 12 were classified as inducers and 9 were classified as inhibitors. What we found that at 3 months, the testosterone levels in patients with BMI more than 30 was 370, and BMI less or equal to 30 was 523. So we noticed that Testopel implantation resulted in an exponential increase and exponential decay after. And in the univariate analysis, both BMI and medications affecting cytochrome 3A4 were found to be statistically associated with serum testosterone in 3 months. And this is what it showed. The significance being the medication, the BMI and the medications affecting 3A4, both inducers and inhibitors. However, the genotype for cytochrome 3A4 was not found to be significantly associated with the decay of testosterone. And this was a little surprising findings because I was thinking that that just couldn't make sense, but it did not pan out. However, we did multivariate logistical regression analysis, and only BMI was found to be statistically significantly associated with serum testosterone levels, as I pointed out in a previous slide. And the other inhibitors and inducers of cytochrome A4 were not significant. BMI was, the p-value was very significant. Adverse reactions were noted in about 5.5% of patients, and all were grade 1 as per Clavian-Dindo classification, which included local pain and swelling, treated with analgesics, superficial bruising, treated conservatively. There were 2 pellet extrusions, 1 pellet in each patient, and these were actually included in the study also, so we did not take them out of the study. There was no infection requiring antibiotics. This is the slide which shows that. So a study suggests that Testopel therapy is a safe treatment option for patients with late onset hypogonadism. Obese patients more than 30 kilogram per meter square body mass index have a significantly higher decay in levels of testosterone at 3 months, thus potentially requiring a higher dose of Testopel in comparison to the non-obese group. So a tailored therapy based on BMI for patients may be justified in comparison to the standard dose. More studies with a larger cohort of patients is required to determine if there are any other variables are related to the decay of testosterone levels. Thank you.
Any questions? This is, I think this is very interesting because, I mean, I think we've seen other studies that have shown different results. Have a couple of questions. Number one, did you measure estradiol levels at all in these patients? Because I think that Andy McCullough looked at this a while back, and he showed that if you gave patients who had high estrogen levels Arimidex, you actually could stretch out the testosterone pellet insertion. And
so yeah, we actually did that on a patient. That's a separate paper. This paper was just we wanted to identify whether cytochrome 3 or 4. That was our main impetus. I was very excited to see if there's a decay in that related to that. However, we also do that if the patients are we see high estradiol levels and the levels of testosterone going down. We treat them with Arimidex 1 milligram a week or up to twice a week or something like that. That should be.
I usually use 10 pellets. How many people in the room do Testopels in their office? Raise your hand. I use 10. Do others use more than 10?
12 to 15.
Okay.
Yeah, I started with 6. I've got a paper, study before this where I have started with 6, then we went to 10, then we went to 12. We had to pre-cert each patient and also tell them about, at that time Slate was reimbursing you for any pellets which were not being paid by the company. Now that it's been taken over by auxiliary vendor, that's a little bit more difficult. I believe, yeah, please go ahead.
There is Cornell. It's a very nice study, and I think it's an important clinical issue. Do you think that the drop in testosterone is just because of the volume of distribution and the dilution? And could you just give us some update about free testosterone and sex hormone binding globulin? Whether, and obviously the ultimate answer would be how the patients feel and the symptom response. But if you could just kind of give us a little bit more information about the free testosterone and sex hormone binding globulin.
Yeah, that's very interesting. Let me answer the last question first. What did they feel? They definitely, these patients, at least more than 85% of the patients actually felt symptomatically worse. They actually came back asking for the level. So we could see a difference when the testosterone level fell. In fact, I had one person who actually knew exactly when his testosterone level would come down, and he used to really pinpoint it with very great accuracy. I don't do a free testosterone per se. I do a calculated free testosterone, and it's just an app. You can go online and get it from issam.com, where you put your sex hormone binding globulin and testosterone level, and it pretty much correlated to the same.